Good afternoon, everyone. iTech India welcomes all the participants for today's Regional Distance Learning Seminar series. Today's topic is HIV and OI, Central Nervous System, and the speaker is Dr. Jaya Chakravarty ma'am. Dr. Jaya Chakravarty ma'am is the professor with the Department of General Medicine, Institute of Medical Sciences, Banaras Hindu University, Varanasi. She is also the Program Director of Center of Excellence in HIV Care and the Nodal Officer for ART BHU, Varanasi. She is a national trainer for HIV and has been involved in training and mentoring of ART centers. She has more than 95 publications with 4971 citations in international and national journals. We welcome you, ma'am, for today's session and request you to start the session.
Thank you, Shweta, for the introduction. So before I start my topic today, actually, I was supposed to do an approach to opportunistic infection as well as CNS opportunistic infection. Now, that's a very, very vast topic, and I said I cannot finish it in 1 hour. So just before I start my CNS opportunistic infection, I would really like to tell you all that opportunistic infection just means something which is already mostly there, it is already there in your body, and it has taken that opportunity of your decreased immunity to manifest itself. For HIV, there's one infection, and which is the commonest, that is tuberculosis. That actually does not vary with CD4. It can occur at any CD4. That should be very clear in your minds. It can occur at 1000 CD4 to 0 CD4. Now, the manifestation of TB, of course, you will read later that it changes with the CD4 count. The others, which are AIDS defining illness, you will be taught in all the other sessions you have, because some will come under respiratory diseases, some will come under GI diseases. But what you need to remember is the infections which occur in HIV are a little bit different than that which occurs in normal people. And usually you're more likely to get protozoal in diarrhea rather than bacterial and viral, which is common in normal people. In lungs, you'll get, of course, pneumonia is very common, but you get a lot of fungal infection like PCP, or you could get PCP, penicillosis and histoplasmosis. And of course, tuberculosis remains one of the commonest OI in the lung. And some of the OIs, it varies with your CD4 count. And if you remember your Harrison's or you remember your UG teaching, you will know that there are certain infections which occur below 200 and certain which occur below 50, like CMV and MAC infections. And others, you will deal with all the opportunistic infections, but when you deal with them, just remember the CD4s, they are commonly seen in. But as a clinical practitioners, you'll see that there is no bar to an infection at any CD4. Just because I can just tell you that there is a patient right now in my ward who has a CD4 of 300 and his serum cryptococcal antigen is positive, and even CSF cryptococcal antigen is positive. So the teaching, there might be something called teaching, but there's something called clinical practice. In clinical practice, you should keep your mind open for anything. Okay. With that, I will come to a very, very important system, that is central nervous system. And I'll tell you the OIs as well as manifestation of HIV in the central nervous system and why it is so important. Shweta, can I have the next slide, please? Next one. Then, yes, now the next. So the contents, just to be a brief, we will touch upon all this many topics, so I have to be a little bit fast, but I will put thrust in certain things which is very common for you all, especially those from UP, and one of them is cryptococcal meningitis. Besides that, I will tell you a little bit about all the other OIs as well as manifestations of HIV. The next slide, please. Okay. So HIV is a neurotropic virus, and it has a predilection to infect the nervous system. And the manifestation of HIV in the nervous system is actually divided into two types. One is directly by the virus itself, the other through other opportunistic infection which affects the nervous system. And we will deal with both of them. And what you should remember is HIV can affect any part of the nervous system. So you'll see the neurology people, they always get a HIV test for everything, whether it is a peripheral neuropathy or mononeuritis multiplex, whether it is a meningitis, transverse myelitis, or encephalitis, whatever, or a space occupying lesion or anything, they will get an HIV, because HIV affects every part of the brain as well as the spinal cord or the nervous neuroaxis as a whole. Now, neurologic manifestation could be the first manifestation in around 10 to 20% of PL-HIV, but it has been seen that 60% of patients with advanced HIV will have clinically evident neurologic dysfunction during their illness. So what we want to trust upon is that it is very, very common to have HIV affecting the nervous system. Next. So I told you it can be divided into two ways. One is OI related. HIV can affect by the OIs, secondary OIs that occur. The other, the patient can be affected by directly the HIV virus itself. So you can, by the direct HIV related diseases are acute aseptic meningitis, which usually occurs when the patient initially has HIV. You can have chronic meningitis also, both due to opportunistic infection and HIV itself. You can have neurocognitive disorder due to HIV, which can, when it is very, very severe, it can lead to AIDS dementia. HIV can directly affect the spinal cord, leading to vascular myelopathy, and it can affect the peripheral nerves too, either by itself or by some of the drugs which we used to use as ART, not now, like stavudine, didanosine, and zalcitabine. And HIV also can cause myopathy, and they are very, very not amenable to treatment, this myopathic patients. The other part of PL-HIV who are affected by opportunistic infections, and they're very common in HIV patients. And one of the commonest, of course, is tuberculosis. The second common after that is definitely cryptococcal meningitis. At least for those in eastern part of Uttar Pradesh, I think this is the second most common opportunistic infection of the nervous system, followed by cerebral toxoplasmosis, CMV retinitis, progressive multifocal leukoencephalopathy, and CNS lymphoma or syphilis. So we will go to one by one to each and every one of them. Next. So how, if you know the syndromic approach to the CNS, it is always very, very easy to make a differential diagnosis and go about your diagnosis. So how does a patient with PL-HIV present to you? So it could present as a meningitis. And how does a patient with meningitis present? They'll have headache, fever, vomiting, and altered sensorium. So when a person has this, then if it is very, very acute, think about bacterial, or it could be some viral. But usually if it is subacute, think about tuberculosis, cryptococcosis, syphilis. Okay. The second way a PL-HIV can present is like a focal cerebral lesion. Here the patient will have headache and focal neurological signs, means either they will have weakness of one arm, or one cranial nerve affected, or hemiparesis or paraparesis, so or convulsions. So when you have focal cerebral lesions, your differential diagnosis as a clinician should be a space occupying lesion first, like tuberculoma or toxoplasmosis, or it could be a diffuse process or multifocal process like progressive multifocal leukoencephalopathy, or it could be a primary CNS lymphoma, which also occurs like a space occupying lesion, but it is much less common than toxoplasma and tuberculoma. And neurocystic sarcosis can affect anybody in India, so it can also affect an PL-HIV. So you should keep all these differentials in a patient who comes with headache and a focal neurological signs with or without convulsions. The other way a patient can present is like an encephalitis, where there's less of headache, fever, and vomiting, but more of altered sensorium, convulsions, cognitive impairment, and psychiatric features. So that means brain parenchyma is involved. So there is your differentials at that time should be cytomegalovirus encephalopathy, or due to herpes simplex, or toxoplasmosis, which can cause both focal neurological deficit due to space occupying lesion as well as encephalitis. But space occupying lesions are much common with toxoplasmosis. A patient can also come with features of myelitis. What is myelitis? The features of myelitis are patient may have sensory disturbances, paraparesis, and bladder bowel. So when we teach you undergraduates, that's what we say. Anybody who has a sensory, motor, as well as bladder involvement, you should think that the spinal cord is involved. Okay, it can be in the form of myelitis if it is some infectious cause, or it can be some myelopathy also if it is non-infectious. So what are the infectious cause which can cause myelitis? That is cytomegalovirus, herpes virus, both zoster and simplex, tuberculosis, syphilis, and less commonly toxoplasmosis. But for us, tuberculosis remains the commonest, though it's written a little bit lower down, but it is one of the commonest cause of myelitis in our sector. Sometimes, and actually it's not very well diagnosed in our ART centers because of the huge burden of patients we have, but many PLHIV will come with neurocognitive decline, where they'll complain of memory loss or behavioral abnormalities, either aggressive or apathic. And along with that, we'll have some motor dysfunction in the form of difficulty in walking. And these all come together. And then your first differential, after you've ruled out all infectious cause and reversible cause like hypothyroidism and hypoglycemia and vitamin B12 deficiency, you should think about HIV-associated neurocognitive disorders. And I will tell you about all these things. I think it's, I'll give you too much information, but then you have your slides, you can look up to them later on. Next, please. So we will start with cryptococcal meningitis next. So why, I'm very happy they've put the slides of cryptococcal meningitis first, because in this part of the country, in the eastern part of Uttar Pradesh at least, we have a very high prevalence of cryptococcal disease. Okay, it is a fungal disease. It is an opportunistic fungal disease, means all of us might be having cryptococci in our body, but we do not manifest the disease. Only those who are immunosuppressed are the ones who have a manifestation. And the most common species which causes this manifestation is Cryptococcus neoformans. But at times you do get Cryptococcus gattai too. Okay. Now, the most important thing which I want you to remember, all of you to remember from this talk is that before you get manifestations of cryptococcal disease, and the commonest manifestation, as you all know, is cryptococcal meningitis. You can have pulmonary also, but that is not that common. So before you have cryptococcal meningitis, immunosuppressed people will have cryptococcal antigen in their blood, that is called cryptococcal antigenemia, much before they have manifestation of cryptococcal meningitis. And it is said that the mean duration before which this cryptococcal antigen will be present in your blood before you have clinical manifestation is 22 days, but it can range up to 100 days. So why is that important? Because this is the time, if you can detect a cryptococcal antigen by a very simple test, you will be able to treat the patient and prevent the much more severe manifestation of cryptococcal meningitis, where we all know the mortality is very high. The drugs given are very toxic. So that should be our intent, to detect cryptococcal antigenemia in patients with advanced immunosuppression. You know the definition of advanced immunosuppression, that is any PLHIV who has a CD4 count less than 200 or has stage 3 or stage 4 conditions. Okay. Now, why this is important to see that, because I told you, because it's quite common, cryptococcal meningitis accounts for around 15% of AIDS-related deaths globally. And why is there so much death? I told you, because one of the reasons could be the difficult treatment. But the most important cause is the delay in diagnosis, because we are not diagnosing, we are just waiting. Okay. And second, to diagnose any meningitis, you have to do a CSF2. So that is the biggest problem because many centers, many of you who are there in this talk, you may not have the facility of lumbar puncture in your system. Okay. Next, please. So how does a patient with cryptococcal meningitis come present? The main thing that you should remember is headache, headache, and headache. Okay? If a PLHIV with a low CD4 count, less than 200, comes with headache, your first differential diagnosis should be either tubercular meningitis or cryptococcal meningitis. Tubercular meningitis usually has a lot of other fever and other 4S symptoms too, but cryptococcal meningitis may just come with headache, may not have fever too. So remember this: headache, headache, and headache. Okay. Almost 65 to 75% may not have the and other focal neurological deficit like cranial nerve abnormalities, etc. Now, the moment a person has cryptococcal meningitis, the word only suggests that the cryptococcus has disseminated. That is why you are having meningitis. I told you that initially when you take the okay, thank you. So how do you diagnose? The next step is, how do you diagnose cryptococcal meningitis? The easiest way, not easy for everybody, but for any meningitis, I told you the way to diagnosis is to take out a CSF. So if you take out a CSF, please remember that cryptococcal meningitis is not an inflammatory meningitis. The whole meningitis is due to the fungal burden which obstructs everything. So the cells may not be raised, the proteins may not be raised, but the sugar may be low to normal because there are a lot of fungi in that CSF. But the only manifestation may be increased opening pressure. Okay, so when you put that LP needle, the pressure will be quite high. Even if you cannot measure it, you can just feel it. The CSF is coming at a very high pressure. So many people, when they see a normal CSF, they'll say, okay, isko to kuch bhi nahi hua hai. So you will not diagnose cryptococcal meningitis if you do not ask your microbiologist to do that India ink stain or cryptococcal antigen testing in the CSF. So cryptococcal antigen testing in the CSF is the best way, easiest way, very sensitive way of diagnosing cryptococcal infection. So this is the last, if you just remember the last line, that is the most important. Okay. And now your cryptococcal antigen tests are very simple and can be done in the OPD itself. And we are trying to do it in our own OPD. Next, please. So what will happen? See, everybody does not have the same facility as BHU. So there are certain settings with access to if there's if you can have lumbar puncture, well and good. You do that CSF, take out the CSF and send for CSF cryptococcal antigen assay. Or you can, if you don't have the cryptococcal antigen assay, you can take the CSF and send it for India ink staining. It is not as good as cryptococcal antigen, but it has a sensitivity of around 65 to 85%. So that is also a good way of diagnosing. But there are many places where you will not get a lumbar puncture done, okay? Or there might be a huge space occupying region where it is contraindicated to do a lumbar puncture. So there, what you can do is serum cryptococcal antigen assay. If that is positive and the patient has symptoms, the best way is to send the patient to a place where the patient can be investigated and treated appropriately. Okay, so many of you will come in the second category where lumbar puncture is not done, but in that place also a serum cryptococcal antigen can be done. Next, please. So what do you do in your OPD? You should ask for symptoms whether patient is has advanced disease, number one, has fever or headache. Okay, so headache, don't forget that. If you can get certain skin lesions which looks like molluscum, or because cryptococcus are also present like the lesions found in molluscum, and in these patients, if the CD4 count is less than 200, you should go for a serum cryptococcal antigen assay. Now, none of you all have it, I know, but in future must be the NACO is going to provide us with serum cryptococcal antigen. So when you have it, this is the best way of doing it. Other than that, most of you all are hospital. Basically, you are a medical college. Most of you are medical college, and most of the district hospitals are being converted into medical college. Please ask your microbiologist to ask to buy certain serum cracked assays, which are very cheap, costs around 400 rupees per assay. Okay, so in those with severe headache, you should have a very low threshold of doing CSF in a patient with who is HIV positive. Very low threshold. Go ahead and do that CSF, and you can do a CSF crack if available. If not available, you can go for a India ink staining and culture for fungus. Okay. Next, the last line, India ink, the negative result does not say that the patient does not have cryptococcal antigen meningitis. This is because India ink is much less sensitive than cryptococcal antigen assay. Okay. Now, can you prevent the disease? I started my cryptococcal meningitis slide with saying that you can prevent if you detect cryptococcal antigenemia early and treat appropriately. Okay. So if you screen people who have advanced disease of and with CD4 less than 200 with serum crack, and if you follow that serum crack positive patient with preemptive antifungal therapy, I'll tell you what is preemptive antifungal therapy. Who in all those who are cryptococcal antigen positive, then you will prevent cryptococcal meningitis and save these people. But because this disease is not very common in children less than 10 years, you do not need to screen them. Okay. And as I've told you many times, this assay is very easy to, it can be done right in your OPDs also. Okay. Next. And it is recommended by NACO for all patients who have a CD4 less than 200, but it is not being done because the assay is not there in most of your centers. Now, what do you do if somebody has a cryptococcal antigen positive in the serum? The next step is to do a CSF. Okay, if anybody has serum crack positive, then you have to take out a CSF and do a CSF crack. If the CSF crack is also positive, then you will designate that person whether they have meningitis symptoms or not as cryptococcal meningitis. Okay. So, and will treat them accordingly as you treat cryptococcal meningitis. And I will tell you this treatment. Okay. But what will you do for those who are serum crack positive, but CSF cannot be done or is negative? Then you decide if it is you cannot do the serum if you cannot do the CSF crack and the patient is having headache and fever, you go ahead and presumptively treat them as cryptococcal meningitis. Okay, but if the serum CSF crack is negative and the patient does not have any symptoms like fever, headache, you just give them preemptive treatment, and I will tell you what that is. Don't put your head on that. Okay. Now, what happens to those who have serum crack negative? These are, when we are talking about serum crack, we are all talking about patients with or without symptoms who have CD4 less than 200. You are supposed to screen everybody, okay? Whether they have symptoms of cryptococcal meningitis or not, that doesn't matter. If you have a CD4 less than 200, everybody should get a serum crack testing done. So if you are serum crack negative, then there's no problem. You look for other OIs. And if it is not feasible, and the patient has fever, headache, better think about tuberculosis and cryptococcal meningitis, and if you better to refer that patient rather than give everything preemptively. Okay. And if the patient has a CD4 less than 200, but you cannot get a serum crack done, then you can give a primary prophylaxis of fluconazole 100 milligram OD in those with CD4 count less than 100. Okay. So if you don't have this, I think this is the last line is important for you. So all the centers who do not have a serum crack available, you will give fluconazole to those who have a CD4 count less than 100 till it comes up more than 100. I will deal with it again in the next slide. Next slide, please. Okay. Now, preemptive treatment, what is that? Anybody who's, I told you, serum crack positive, does not have symptoms of cryptococcal meningitis, you will give preemptive treatment. And it can be given in pregnant women as well, because you're giving fluconazole. Fluconazole can be given in pregnant women also. But all these people, before giving that preemptive treatment, it is much better to do a CSF and CSF crack to rule out asymptomatic cryptococcal meningitis. If the crack is positive in the CSF, that is designated as cryptococcal meningitis. Okay. So next slide, please. So what is this preemptive treatment? Now, usually what we give is, in our center, we give fluconazole at the dose of 800 milligram for 2 weeks. Then in the consolidation period, we give 400 milligrams, because the recommendation is from 400 to 800 milligrams you can give for 8 weeks. And then we maintain the patient on 200 milligram of fluconazole till the CD4 count becomes more than 200. Next, please. Now, what do you do for ART initiation? Now, if the patient has cryptococcal meningitis, that is CSF crack is also positive as well as the patient is symptomatic, then you will defer the ART at least for 4 weeks. But other than that, ART can be given if the patient doesn't have features of cryptococcal meningitis. You can, if you're giving preemptive treatment, you can just give initially, because you're giving a very high dose of fluconazole. You can start ART. There is no restriction of starting ART, but I would like to wait for 1 week before, so that the patient can adjust to the high dose of fluconazole, and then you can start ART. Or if the patient is not likely to come back, you can start ART as well as preemptive therapy together. But for cryptococcal meningitis, you have to wait for 4 weeks before you start ART. Okay, next, please. Okay. So let me just consolidate what I've already said. If in your center serum crack test is not available, you can start primary prophylaxis for cryptococcal meningitis in all PHIV who have a CD4 count less than 100. And the dose is fluconazole 100 milligrams OD. Now, there's a huge variation of fluconazole doses. So please keep the slides with you. This is 100 OD. Secondary prophylaxis is 200 milligram. And of course, treatment is very, very high. I'll come to that. Okay. Now, when do you stop this fluconazole? This is called primary prophylaxis, because the patient has not had the disease as yet. Okay. Now, for when will you stop this primary prophylaxis? When all the following criteria are met. The patient does not have any cryptococcal disease. It has been given for at least 1 year, and the CD4 count is more than 100 cells per millimeter cube, and the patient has a suppressed viral load. Okay, so when you have all this, you can stop the primary prophylaxis of fluconazole 100 milligram OD. Next, please. Okay, so I told you two things: primary prophylaxis, preemptive treatment if you don't have serum, if you have a serum crack positive but CSF crack negative. And now we are coming to the treatment of cryptococcal meningitis, which is quite complicated, very expensive, and quite labor intensive, and cannot be given in a ART center or OPD basis. Now, how do we treat? We, in our center, we give Amphetamine B at the dose of 1 milligram per kg, along with flucytosine, which is quite costly, for 1 week. And then we follow it by very high dose of fluconazole, that is 1200 milligram daily for another week. But some people may not have access to amphotericin B, and there you can give both oral drugs, that is fluconazole plus flucytosine. But I know none of you have access. Very few of you will be having access of flucytosine, because we got it specially for our patients, and it is very, very costly, and it has to be monitored because it can cause bone marrow suppression. And the other alternative is 2 weeks of amphotericin B and fluconazole at very high dose. Now, these are the alternatives, but the best regimen and the preferred regimen is amphotericin B deoxycholate plus flucytosine for 1 week, followed by high dose of fluconazole 1200 milligram for 1 more week. And this is the induction phase, and this will be followed by a consolidation phase. Next, please. In the consolidation phase, we give fluconazole at the dose of 400 to 800 milligram daily. We usually give 800 milligram daily for 8 weeks, and then we maintain it at a maintenance dose of 200 milligram daily till the patient is free of cryptococcal disease and has been taking treatment for 1 year, and the CD4 is serially more than 100, and the patient has a suppressed viral load. Here, I would like to tell you this, that many patients with cryptococcal meningitis come with a CD4 more than 100 and in between 100 to 200. So there we will keep on giving the secondary prophylaxis till the CD4 count is more than 200. Okay. Next, please. In the treatment of cryptococcal meningitis, because there's a lot of raised ICP or intracranial pressure, you have to take out the CSF and throw it out multiple times. That is what we do in our wards. Just take out CSF if the patient complains of headache, or the if you measure it and the CSF pressures are high, we just take out the CSF and throw it. And either you can do that multiple times, or you can also put a CSF drainage. That is a little bit more invasive. So because if you don't do that, patient will have other features of raised ICP, and the patient can lose their vision. We have patients who have lost their vision, and they can have other focal neurological deficits also. Okay, so management of raised intracranial pressure is very, very important, and the best way of doing it is just taking out CSF and throwing it, because the other methods like mannitol, acetazolamide, and steroids do not work for cryptococcal meningitis. Okay, next, please. So I know none of y'all, very few of y'all must be giving amphotericin B. Amphotericin B is a very, very toxic drug, especially the conventional one. The liposomal amphotericin B is quite good. It causes less of nephrotoxicity and less of dyselectrolemia, and but mostly it's very costly. So 1 vial costs around 6,000. So it is beyond the reach of most patients. So the conventional amphotericin B deoxycholate, if you have to reconstitute in sterile water, and you have to add in 5% dextrose. You cannot add it in normal saline. Please remember that. That is why it is put over there. Okay, and it has to be given slowly in the peripheral lines, and it causes a lot of thrombophlebitis. Okay, and you have to give this whole infusion in at least 4 hours. And the first 10 minutes is very important. You give very slowly in the first 10 minutes to see whether the patient is having any toxicity. And you can have anaphylaxis also. You can have severe myocarditis with amphotericin B. So the first 10 to 15 minutes, you can wait till half an hour also, is the time where you should monitor these patients. Okay, next, please. All patients who are given amphotericin B. So what we do in these patients, in the morning we give them 1 liter of normal saline, and in each of the bottle we give 1 ampule of potassium chloride. Why? Because amphotericin B leads to hypokalemia due to loss of potassium in the urine. It causes a tubular acidosis. So that is why we give this normal saline and potassium chloride, because that also decreases the toxicity, renal toxicity of amphotericin B. Then also you should supplement potassium and, if possible, magnesium, because they will have hypokalemia. Okay, so they can give pot chlor, which is easily given but not easily taken. because it's very not tasty at all. And to minimize the risk of phlebitis, I told you a lot of phlebitis occurs. Every time you finish the dose of amphotericin B, you should flush that tube with, flush the line with normal saline. Okay, next. Amphotericin B, because it is quite toxic, you should get a serum creatinine and serum electrolyte done, especially serum sodium and potassium on day 0, day 3, and day 7, because you're giving it for 7 days. And you should also get a CBC done because you're giving flucytosine, and which can cause pancytopenia. And even amphotericin B, it can cause thrombocytopenia and anemia times. Okay, and you have to tell the patient कि जब भी मैं ये दवा चलाऊं, जब भी हम दवा चलाएंगे तो बुखार आएगा तो घबराना नहीं है. So you pre-medicate the patient with paracetamol, and at times we give Avil also because the fever comes with chills and rigors. So we give Avil and paracetamol as a pre-medication, and very, very rarely if the patient has very severe reaction, we give hydrocortisone, because I don't want to give hydrocortisone in a patient who's having fungal infection. Okay, next. So some people may have relapse of cryptococcal meningitis because of inadequate induction therapy, non-adherence to fluconazole, because you are supposed to take that secondary prophylaxis, which is 200 milligram, not 100 milligram like primary prophylaxis, for a long time. Some people may have fluconazole resistance, and some may have cryptococcomas inside the brain, which may require longer therapy. Okay, and the patient might have had cryptococcal meningitis long back, 10 years back, and now he's failing his first line, and his CD4 count has come down to below 200, and you did not notice it. The patient may have a relapse of the previous disease, because cryptococcus is in your body, you are not clearing it off. Okay, so if you have a relapse, treat it as a meningitis and give the whole meningitis regime again. Okay, next please. Now you can have iris also in patients who have cryptococcal meningitis, but it is very difficult to when you need to differentiate this iris from a relapse or drug-resistant cryptococcal meningitis, like you do in tuberculosis. And in iris, what will happen is the cells will increase because there's more inflammation, but your culture, the CSF culture, fungal culture, will be negative. Serum crack should not be done for iris, because a serum crack from the CSF goes off in a very long time. So that will not help you. So don't do that serum crack. You have to go for fungal culture. Okay. Now, as you know, all irises occurs months after ART initiation. And if you have very severe iris due to cryptococcal meningitis, you might give steroids to decrease the inflammation. Okay. But you need to differentiate it from relapse. If it is a relapse, the culture will be positive. Okay. And the treatment, if for paradoxical iris, if there is raised ICP, you just have to take out the CSF and throw out, or put a drainage in the CSF to drain out the CSF. That is what you can do. Okay, but please send a fungal culture for all patients who are suspect of cryptococcal iris. Next slide, please. If there's a persistently elevated ICP, maybe you will need some neurosurgical intervention, and for that you need to refer the patients to a other center. But if a patient with cryptococcal meningitis is deteriorating, think of other etiologies like cryptococcal meningitis, bacterial, because every time you're putting that needle, you are putting that patient at a risk of bacterial meningitis, or some space occupying lesions. And before you just label iris, and that is what you do for iris, for any sort of iris. You rule out other infection, you rule out drug-resistant infection, and then you label it as iris. Next, please. Now, this is very, very complicated. I'm not going to do this with you, but I'm going to tell you in a very, very simple way. Any patient who comes with advanced disease, that means has a CD4 count less than 200, or has fever, altered sensorium, headache, that is signs of meningitis, you have to do a serum crag. Okay. Now, if you do a serum crag, and if the serum, next slide, please. Of course, you look for other OIs also, do the CVNAT if the sputum is there, or you can do a CSS CVNAT if you're thinking about tubercular meningitis. Okay. And then if the CD4, if the serum crag is positive, you do a CSF crag. Okay. And if the CSF crag is positive, you treat the patient as cryptococcal meningitis. Whether the patient has symptoms or not, that is not essential. If the CSF crag is positive, treat it as cryptococcal meningitis. But if the serum crag is positive and the CSF crag is negative, then you give the preemptive treatment for 12 weeks, that is 800 milligram for 2 weeks, 400 milligram for 8 weeks. Okay, and then continue at the prophylaxis. Sorry, I lost the slides.
Ma'am, 2 minutes.
Yeah. Okay. Now, if you do not have a facility to do a serum crag, then what are you supposed to do? Then you have to follow that primary prophylaxis. If the patient has a CD4 less than 100, give primary prophylaxis for cryptococcal meningitis, fluconazole of 100 milligram. If you have facility of serum crag, but not a facility for CSF crag, you do the serum crag. If that is positive, please send to a center where CSF can be done. That is the best way of doing things. But if you can't send the patient, but the patient has a symptoms of meningitis, then the other option is to treat for cryptococcal meningitis, which again you will not be able to do. For you, if the serum crag is positive, if you can't do a CSF crag, send the patient to a higher center. Okay. And before I end this cryptococcal meningitis, in our center, we have had 15% patients with CD4 less than 200 asymptomatic patients who to be having serum crag positive. Okay. Now, out of this 15%, 50% had CSF crag positive. Okay. So they had cryptococcal meningitis, which was still asymptomatic. And when we treated this patients who had CSF crag positive with the treatment of cryptococcal meningitis, none of them died. But we also had patients referred to us from other centers who had cryptococcal meningitis symptoms, and then we did a CSF crag which was positive. Death was much higher in those patients, though we treated them as cryptococcal meningitis. So please remember, cryptococcal screening for cryptococcal antigenema is very, very important. And we will ask UPSACs to provide us with this kit because it is very common, especially in the eastern part of the state, right? Of course, Banaras, Gazipur, most of our patients are from the eastern part and Bihar. So we get a lot of cryptococcal meningitis. Next slide, please. So we come to the next opportunistic infection, that is toxoplasmosis. Next, please. Now, what is this toxoplasma? Toxoplasma, of course, it is a protozoa, and it can cause a encephalitis. It is called Toxoplasma encephalitis, and the organism is called Toxoplasma gondii. And you get this, again, this infection is already there in your body, okay? And it takes the opportunity of your decreased immunity to manifest itself as a encephalitis, okay? And it occurs by eating contaminated food, which is contaminated with the oocysts of Toxoplasma from the cat feces or other animals, okay? Now, it is a very common cause of focal brain lesion and usually occurs less than CD4 200. And the people who have a CD4 less than 50 are at highest or greatest risk. You had a question, I think, on that. And it is not transmitted from person to person because I told you how it is transmitted because from cats' feces. Okay, next, please. So it's not an acute transmission. You get this disease when you already have that disease. Okay. Among what is the clinical manifestation? Now, the patient may have headache, confusion. It can present as encephalitis or it can present as focal neurological deficit, okay, abnormalities. So the patient may have fever, headache, confusion, or the patient may have focal neurological deficit like hemiparesis, monoparesis, cranial nerve abnormalities, etc. Okay, the patient may have seizures also, And if you don't treat it at the right time, the patient may go to coma and there may be death also. How do you diagnose it? You can do a MRI. MRI is excellent for toxoplasma, but it is not definitive. So where you will see multiple ring enhancing lesions, okay, in the gray matter, and it is commonly in the cortex or the basal ganglia, and these ring enhancing lesions, which are actually the contrast which is surrounding the focal lesion, that may be surrounded by lots of edema. Okay, it can have a single brain lesion, or toxoplasma can also cause diffuse encephalitis without evidence of focal brain lesion. Okay, next please. So how do you diagnose it? Of course, you can, the best way of diagnosing it is MRI, but the definitive diagnosis is by doing a biopsy, okay, because a ring enhancing lesion can be caused by many organisms. Okay, now what we do is a serum IgG, not IgM. Toxoplasma is never an acute infection. Okay, so if you have already been infected with toxoplasma, your serum IgG will be positive. But that does not say that you have a active disease. That means you are more likely to have a toxoplasma disease. So if you have a serum IgG positive and a ring enhancing lesion, then your chances of having toxoplasma is very high. But if you have a ring enhancing lesion and the serum IgG is negative, for toxoplasma is negative, then your chances of having toxoplasmosis is very low. Okay, that is the only role of serum IgG. It does not say that the patient is having active disease or not. Okay, but MRI lesions, they help, but they are not definitive. You need a biopsy for that. You can do a PCR, but again, the sensitivity of PCR is not good. Okay, so for definitive diagnosis of toxoplasma related encephalitis, you need a clinical syndrome, and you should have ring enhancing lesions, and of course, if you can get a biopsy, fine, but nobody does a biopsy. So what we do is give empiric treatment and see whether the ring enhancing lesions are going or not, because these lesions clear off very easily around 6 to 8 weeks after therapy. That is one way of doing things. Okay, because biopsy is very difficult to do. So next slide, please. So you should think about toxoplasmosis when the patient has headache, confusion, focal neurological deficit, seizures. So if these patients have this, then you can ask for an MRI, because that is the first thing you will do in any person who has focal neurological deficit. Okay, and then you can do a serum IgG, but that only helps. It is not a way of doing of diagnosing, giving a definitive diagnosis for toxoplasmosis, because if the serum IgG is negative, there's very less chance, less than 5% chance of the patient having toxoplasma encephalitis. Okay, so read the last line. Always perform imaging first, because it can have focal lesions, and if you don't do an imaging first and do a lumbar puncture, then they might be coning. And even if you're doing lumbar puncture in a patient because you do not have the access to CT scan or something like that, then do a very, very guarded lumbar puncture. Okay, next please. So how do you treat? Okay, before that, the differential diagnosis. Now, if you remember ring enhancing lesion, you've been taught since UG, the commonest cause is tuberculoma, toxoplasma. In HIV, CNS lymphoma is the most difficult thing to differentiate from toxoplasmosis. Okay, so the MRIs cannot differentiate toxoplasma from CNS lymphoma. That is where you need a biopsy. And the other things, tuberculoma and all, you can differentiate it by doing a CSF and looking for basal meningitis. PML is actually not a great differential diagnosis, because MRI for PML is very, very different. Okay, and it is very easily diagnosed. Progressive multifocal encephalopathy is very easily diagnosed by MRI. So the main differential diagnosis and confusion in toxoplasmosis is with primary CNS lymphoma. Okay, but the other things, it could be tuberculosis, it could be cryptococcosis, it could be a pyogenic brain abscess, but the patient will be much, much sicker. Okay, come on, next slide, please. So how do you treat toxoplasmosis? You are supposed to give pyrimethamine at a very high dose initially, and then pyrimethamine plus sulfadiazine plus leucovorin. Again, you will not get these drugs very easily. You have to specially order for them, and we have ordered because UPSACS gave us a lot of fund for OI treatment, and we are thankful for that. But if you don't have anything, look at the last line. You can give your your trimethoprim and sulfamethoxazole at a BD dose, and that works for toxoplasma too. But the best option is, of course, pyrimethamine plus sulfadiazine plus leucovorin. But if you don't have access to those drugs, you can give your trimethoprim and sulfamethoxazole too. Next, please. And the total duration of treatment is 6 weeks. So if you have to do a MRI to see whether the lesions have cleared up or not, 6 to 8 weeks is the best time to get it done. After 6 weeks is the best time. Okay. Then what about maintenance? Maintenance is again the same drug at a lower dose. So you keep on giving pyrimethamine, sulfadiazine, and leucovorin, but at a much lower dose. And if you're giving trimethoprim and methoxazole, it is the actually you can continue the same dose, or both are recommended. You can give the single, but we give a higher dose. We give the BD dose for our patients who are on trimethoprim and sulfamethoxazole. Okay. How, when do you discontinue therapy? You will discontinue therapy when the CD4 count is more than 200 cells per microliter for more than 6 months. That means you do 2 CD4 counts and both are more than 200, then you stop the prophylaxis. Okay. Why are you giving the secondary prophylaxis? Because the protozoa is still in your body. So again, if your CD4 comes down, the patient may manifest and have a repeat of the disease. Next. Now, prophylaxis for toxoplasma can be primary also. You don't know, I don't know whether you know or not, when you give your trimethoprim methoxazole for PCP, it also protects you from toxoplasmosis and many of the bacterial diseases, including some causes of diarrhea. So that is called primary prophylaxis. The patient has not had the disease, but once you had toxoplasma, you have to give secondary prophylaxis, and that secondary prophylaxis has to continue till your CD4 count is more than 200. And it has to be restarted if the CD4 count again comes back to less than 200. That should be very, very clear in your mind. And the primary prophylaxis dose is 1 double-strength tablet of cotrimoxazole. Okay. And if the patient is allergic to cotrimoxazole, you can go for dapsone, but again, cotrimoxazole is much, much better than dapsone any day. Okay. Next, please. Then we come to a viral disease. Again, which is already there in most of us. Most of us will be infected with cytomegalovirus, but the disease is manifested only in immunocompressed, compromised people like HIV and anybody who gets chemotherapy or a lung transplant or a transplant surgery. Next, please. So, what is the commonest manifestation of cytomegalovirus in HIV? It is retinitis. Okay, that is a commonest, but it can affect any part of the GI also. Okay, so the second common is CMV colitis. At present, we have one case of CMV retinitis, the other case of CMV colitis, and we just had one case of CMV pneumonitis also. Okay, so retinitis is the commonest, colitis comes second, esophagitis is also common. And you have certain neurologic manifestation which can be caused by CMV. I'll come to that and tell you. But the commonest is retinitis, and our program is focused mainly on retinitis. Okay. Most clinical disease will occur when the CD4 count, patient has an advanced disease, that is the CD4 count less than 200. And CMV retinitis usually occurs when the CD4 count is very low, less than 100. Okay. Why we are really concerned about retinitis, because many people may have asymptomatic painless loss of vision. So if you don't think proactively about CMV retinitis, you're going to miss these people and the patient may lose their vision permanently. Okay, that is why we go on thrusting about CMV retinitis to all of you. Next slide, please. Okay, because once the vision is gone, nothing comes back. Okay, because if the lesions were initially in the peripheral part of the retina, it causes retinitis. So if it is in a peripheral part of retina, you may have peripheral visual field defects which the patient may not tell you about. Okay, only when it has a central lesions, then you will have decreased visual acuity or field defects. And the only way of diagnosing it is by doing an ophthalmoscopic examination, where you'll find a lot of, we'll show you the image later on, the fluffy yellow-white retinal lesions with or without hemorrhage. Okay, so then in the absence of ART or specific anti-CMV therapy, the patient's retinitis will invariably progress within 10 to 21 days. So it is an emergency. Okay, so every patient who has a CD4 less than 200, and if you can't screen everybody with 200, less than 100, definitely you should have an ophthalmoscopic examination to rule out CMV retinitis before you start ART. Because the moment you start ART without giving treatment for CMV retinitis, the patient is going to lose his vision and the CMV retinitis will worsen. So it is a medical emergency. Next slide, please. So the other manifestations can occur, but are less common than retinitis. The patient may have colitis, which means colitis. Patient with colitis come with diarrhea, pain abdomen, tenesmus, blood in the stool. Okay, that is common for all colitis. So CMV colitis is nothing special, but then you have to get a biopsy done, and you get the CMV inclusion bodies in the biopsy of the colon. The patient can also present with esophagitis, where the main complaint will be odynophagia. When we think about odynophagia, the first thing that comes to our mind is candidiasis, but many times it may be due to CMV. So again, you have to put an endoscope and do a biopsy, and then you can diagnose CMV like that. In CMV neurologic disease, there are two types of presentation. It can come as encephalitis. Okay. The other manifestation is, it comes very specific for CMV, is polyradiculomyelopathy. Means it involves many radicals. Okay, and usually the sacral radicals. So the patient will have a lot of bladder problems, and they may have asymmetric weakness of the lower limbs. Okay, so that is very specific for CMV. And of course, CMV can also cause something like GB syndrome. But the commonest is involvement of multiple radical as well as bladder involvement. Okay, next slide, please. So how do you assess and look for retinitis? So any patient who has a CD4 less than 100, you can ask for diminishing vision, but you may not get, the patient may not have signs and symptoms, because the patient may not be assessing their peripheral visions. So anybody with CD4 count less than 100, it is prudent to get an ophthalmological examination by an ophthalmoscope. Okay, and you have to rule out CMV retinitis before starting treatment. Next, please. This is how it looks. A lot of fluffy shadows, white fluffy shadows with some hemorrhage. You can see the next second, you can see hemorrhages along with exudates. The white ones are the exudates. Okay, and this is how it looks. And it is actually a clinical diagnosis. You do not have to do any blood test to make a diagnosis of CMV retinitis. Okay, for CMV polyradiculopathy, you can do a CSF PCR. For CMV colitis, you can get a biopsy done. But other than that, for CMV retinitis, definitely you don't have to do a PCR or anything. This, if you have such a picture, CD4 is low, go ahead and treat. Okay, so how do you treat? We'll come to the next slide. So how do you treat CMV retinitis or colitis for that matter? Next slide, please. So the drug of choice is ganciclovir. Okay, it should be treated for at least 3 to 6 months, and till the patients have the lesions are inactive and the CD4 count has improved to more than 100 cells per millimeter cube or a microliter. And you have to consult an ophthalmologist before you start. They have to see whether the vision and the lesions are stable or not. Okay, and next slide, please. For all the opportunistic infection, if you just see, there is a line in every slide that if you do not have the drugs for OI treatment, please approach your SACs. We approached our SACs, UP SACs, of course, and they did give us a lot of money for treating opportunistic infection, which has really helped our patients. So you can also ask for that, because most of these drugs won't be there in your hospital. Okay, so what is the drug of choice? The drug of choice is either valganciclovir or ganciclovir. Okay, the doses are as given. You for therapy, you give Valgan of 900 milligram orally every 12 hours. You get capsules of 450 milligram, so 2 tablets BD for 14 to 21 days. Or you can give IV ganciclovir 5 milligram per kg 12 hourly for 14 to 21 days. This is for therapy. But then after that, next slide, please. That you have to continue the valganciclovir at a dose. Once you've given the initial induction phase of 14 to 21 days, then the patient has to be put on Valgan at 900 milligram OD, and that needs to continue for at least 3 to 6 months till the ophthalmologist say the lesions are stable, there are no new lesions, and the others are resolving, till the CD4 count is more than 100. Okay, so there's a long period where you have to give valganciclovir at the dose of 900 milligram once daily. Okay, for the treatment part, it is twice daily. For the maintenance part, it is once daily. Okay, again, if the CD4 count later on in the patient after 10 years, the CD4 count goes below 100 in a patient who have already had CNV retinitis, you have to restart. Okay, the maintenance therapy, so that the patient does not get a recurrence of CNV retinitis. Next, please. The other treatment for other lesions also remains the same. Next. For esophagitis or colitis, the treatment remains the same. Next, please. Again, the treatment does not change. It is ganciclovir. For retinitis, you can give valganciclovir, but for other disease, Valgan has not been tested, so it is better to give, more prudent to give ganciclovir. In our center, for severe retinitis, we do give IV therapy for 14 to 21 days and then put the patient on Valgan as an oral therapy. Okay, so oral valganciclovir actually for neurological and pneumonitis, it has not been established where it is better to give IV valganciclovir. Next, please. Now I have to ask Shweta one question. Shweta, it's already 3. Do you want me to continue, or do you want me to do this session again? Because I don't think so. They'll because there are lots of slides left. So
right, almost 30 slides, ma'am.
Yes.
Ma'am, can you give me a time slot again then for this session?
Yes.
Maybe this
I
week.
will, because there's no use pushing something which they'll not remember.
Yes. Right, ma'am.
So,
it's okay, ma'am.
we can ask them questions.
Yes.
Yeah, we can stop here and ask them if they have any questions regarding the 3 diseases we did.
Sure, ma'am. Any questions from the participants? Please feel free to unmute your mic, or you can even type in the chat box. Any questions so far?
If not, can I ask question then?
Sure, ma'am.
So, who's there from ART RML? Can you unmute yourself? The doctor over there. I can see ART RML.
ART Center, RML, can you please
RML is in Lucknow, yeah. I don't think so they are hearing. ART Saifei then. Can you unmute? Can they unmute?
Yes,
Is
yes,
there a
ma'am.
function
Yes,
for?
ma'am. Yes, ma'am. They can unmute.
Okay. They've all gone to sleep, that means, Shweta.
Oh,
Is
maybe
there
the
anybody from
doctor
UP
is not
SACS here?
attending. No,
Is
ma'am.
there anybody
No
from
representation
UP
from
SACS?
SACS.
No. Because it was very important for SACS to be present, because most of the drugs we are giving here for the management of OI are not available very commonly. So they need help from SACS. So if there are
Okay.
no questions, maybe when I finish the next part of this whole
Sure, ma'am.
CNS,
What
I
you can
can
do
ask.
is you can give us questions that can be put as the e-poll, since we'll be having a bit time in the next session. We also have questions in the post test, so maybe questions from there, or you can give us separate questions and we'll put them as e-poll.
Yeah, I just wanted to know whether they understood how to do a
Right.
cryptococcal screening or
Right,
not.
ma'am.
That's very
Right, ma'am.
important. They didn't understand. There's no point of this whole training program.
Right, ma'am. Right, ma'am.
So we'll do it again then, Shweta.
Sure, ma'am. Thank you so much, ma'am.
Thank you,
I'll get
everyone.
in touch with Vishal, sir.
Okay.
Thank you so much,
Thank
ma'am, for facilitating this
Thank
session. Thank you to all the participants for patient listening. We'll continue with this session in this week or next week. I'll let you know accordingly. Thank you, ma'am. Thank you, everyone.